everybody. Welcome to our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here, and today I'm joined by Dr. Nagy from our ENT department. Thanks so much for joining us. We're going to ask a few questions. Today our topic is on sleep apnea, so if you have any questions along the way, be sure to post them in the comments section, and Jenny is here with us, and she'll be asking them out loud. So if you wonder who that voice is, it's Jenny. All right, so we will just hop right in. Thank you for being here with us today. Our topic today is sleep apnea. So first and foremost, what is sleep apnea?
Sleep apnea is a disorder of breathing during sleep that's characterized by either prolonged periods of hypoventilation, where you're taking very shallow breaths, or complete obstruction, where you're not moving any air at all, leading to basically an abnormal respiratory pattern while you're sleeping.
Okay, and what causes sleep apnea?
There's a variety of causes. In children, I would say the most common cause is probably enlargement of the tonsils and the adenoids, but there's a variety of factors that play into sleep apnea. So first, there's central sleep apnea and obstructive sleep apnea. So in order for us to breathe, we first have to get a message that's sent from our brain down to our lungs to tell us to take a breath. So first we have to have the message telling us to breathe. When we don't have that message and we have no respiratory effort because our brain hasn't told us to breathe, that's a central apnea. For obstructive sleep apnea, our brain is telling us to breathe and our lungs are trying to breathe, but there's obstruction somewhere else above our lungs as they're trying to expand. So if you think about our respiratory system, we usually breathe through our nose during sleep, or that's the goal. So it can be anything from the tip of our nose, the turbinates or the soft tissue that are inside of our nose, the adenoid, which is basically tonsil tissue that's at the back of the nose, tonsil tissue, which is at the back of the throat, but can also be a large tongue, a narrow pharynx or throat, other abnormalities or strictures or stenosis of the rest of the airway. So there's a lot of areas along the respiratory tract that can have enlargement or areas of narrowing that we can potentially address surgically. And then the last component of that is we have to have good muscular effort to take good breaths. And so a lot of children that we see that have various syndromes or neuromuscular disorders like muscular dystrophy, they may also have difficulty taking in those big deep breaths, and so their obstruction may be more from hypoventilation or not a good muscular effort to take a good deep breath during sleep. Okay. So there's a variety.
There is, and
lots of stuff going on.
Is there one that's more common than the other, especially in children?
I would say in healthy children, the most common cause is absolutely tonsil and adenoid enlargement, and that's why tonsils and adenoids, tonsillectomy and adenoidectomy is the first line treatment for treatment of obstructive sleep apnea in children. Okay. Whereas in adults, first line treatment is CPAP, or what we call continuous positive airway pressure, which is a mask that you wear during sleep that actually blows air into your airway to kind of keep things stented open. In children, the first line treatment is surgical, taking out the tonsils and adenoids.
Okay, is there a reason that that's the first line for children but not for adults?
Well, there's different reasons to have sleep apnea. In adults, I would say overwhelmingly we see a lot of adults that are obese and have a little bit of some different anatomy. In children, we see a lot of, skinny kids with huge tonsils that you're like, I don't know how you're getting any air when you're breathing in. And so even in children that have that don't have other risk factors for sleep apnea, like obesity, they can still have large tonsils and adenoids that contribute to obstruction.
Okay. Are there certain populations that are more prone to sleep apnea than others, or is it an equal opportunity offender?
No, it is not. So definitely obesity increases your likelihood of having sleep apnea, and as obese children and obesity in kids continues to rise in America, we're seeing more and more obstructive sleep apnea in kids. So definitely obesity is a risk factor. Craniofacial disorders, so children that have abnormalities in their craniofacial skeleton are at more risk of sleep apnea. And in general, that's because the structure of their face and also mid-face and other structures within that area are smaller, have different various abnormalities that can contribute to obstruction. Like we kind of talked about, children with neuromuscular disorders or poor muscular tone are also at risk of sleep apnea, among others I'm sure that I'm leaving out. But that's kind of, and Down syndrome is another big one that we see a lot.
Okay. How serious is sleep apnea? I mean, if you can't breathe when you're sleeping, I'm imagining it's pretty serious.
It's more serious than we, I think, had previously thought. You know, a lot of people have known about obstructive sleep apnea for a long time in the adult population. But I don't think that pediatric sleep apnea really hasn't been addressed, and people didn't really start knowing about it, I don't think, until like the last decade. And so now we're getting more and more research that shows that obstructive sleep apnea, even in kids, can cause problems. So what are some of those problems? In general, when kids don't sleep well, they're not going to act well. So, you know, in an adult, a lot of times an adult can express like, I'm exhausted, I'm tired, like I need a nap, I'm going to fall asleep right now. In kids tend to act out whenever they're asleep. They may not express that they're tired. So a lot of times kids with obstructive sleep apnea may actually have the opposite. You may see hyperactivity and attention deficit disorder. They may express that they're tired. A lot of other times you might see that there's inattention or problems with concentration at school or at home. You might see emotional lability or behavioral problems with acting out with obstructive sleep apnea. And so those are some of the, intangible things. Medical things that can happen with obstructive sleep apnea can include hypertension, if left untreated, pulmonary hypertension, and even if that is left untreated, that can go on to affect the heart. So there are some medical complications of not treating obstructive sleep apnea as well, in addition to some of the behavioral things. Another thing that parents can come in and tell us that they've noticed in their kids is bedwetting. So bedwetting is actually something that can be associated with sleep apnea and can improve after removing tonsils and adenoids.
Okay, that's good to know.
Yeah.
Do you see it appear more at a certain age, or is it sort of any age, any child?
It can be any age and any child, so it really can be even in infants, all the way through, our adult population, as you've seen. There might be different reasons why in different age groups, but you can see it in any age group. In terms of the tonsils and the adenoids, we see it kind of in that younger childhood period, maybe between the ages of like 3 to 9, when tonsils and adenoid size is at its largest. Okay. But it can occur in any age group. In terms of gender distribution, it's equal between sexes and children. Okay. In adults, males are far more common to have obstructive sleep apnea than women are, but in the pediatric population, it's pretty equal among genders.
Okay. And for surgery, what does that process look like from diagnosis to being in the operating room to aftercare? Can you walk us through that?
Yeah. So I would say that symptoms that bring kids into us is like where the consultation starts. So things that parents may want to be on the lookout for, or things that pediatricians notice and have them sent over, is snoring. Mouth breathing, so walking in and your child's definitely not breathing through their nose, they've got their mouth open, restless sleep or fragmented sleep, frequent awakenings during the night, and then obstructive events. So I have parents that come in with videos on their iPhone all the time that they're like, look at my kid, they're taking pauses in their breathing, or they're snoring, and then there's silence, and then they're snoring again, or they wake up with a gasping, trying to catch their breath after one of those obstructive events. So those are some kind of things that that parents kind of notice during sleep, in addition to some of those daytime things that we kind of talked about, inattention, behavioral problems, emotional lability, those kinds of things. So that gets you in the door, those concerns. When you come in for a consultation, we do a full upper airway evaluation. We're looking at the nose to see if there's any obstruction in the nose. We look in the mouth. We're assessing, the tongue size, the tonsil size, all of those kinds of things. And like I said, the first line treatment, if we recommend, if you have those symptoms and you have enlarged tonsils and adenoids, then the next step that we would talk about is one of two things. One thing we can get is a sleep study. Okay. A sleep study is the gold standard for diagnosing obstructive sleep apnea. So if parents are not sure if they want surgery and they just want to know, does my child actually have sleep apnea or are they just snoring? You can get what's called a sleep study where you come in and actually we observe you sleep overnight with lots of monitors on. We monitor EEG, your breathing, your oxygenation. So we breathe in oxygen, we exhale carbon dioxide. So we monitor both of those. And then we can get some more quantitative data on how many times is your child obstructing? How many times is your child taking, those shallow breaths? Is your child's oxygen level dropping whenever these events happen? Or are they not able to exhale? Information, then we can get a sleep study to better quantify exactly what's going on.
Do you do those here?
We do. Okay. We have a wonderful sleep center here, and we have the board certified pulmonologists and neurologists that read our sleep studies here because they are read differently than adult sleep studies because our kids are not just small adults. And so that's all done in-house.
Oh, great.
And so sometimes parents want more information. Sometimes we want more information. So situations where I would say I definitely want a sleep study before I offer surgery are children that are obese, so their BMI or body mass index is above the 95th percentile for their age and gender. Down syndrome or other craniofacial syndromes, any neuromuscular disorder, muscular dystrophy. Those are some of the reasons why we would say, I think that we should get a sleep study first. Or parents come in with lots of symptoms, but you look in the mouth and the tonsils are not large. So you're saying, is something else here going on? Or I want a little bit more information because I don't know that taking the tonsils or the adenoids is going to be helpful because they look small on exam. Okay. So those are some reasons that we might want to get a sleep study before offering surgery. Other times, if we have a healthy kid with huge tonsils and adenoids and symptoms, we may go straight to surgery and offer a tonsillectomy and an adenoidectomy as a first line. Okay. There are other surgeries that can also treat sleep apnea. So sometimes we see really significant sleep apnea, and sometimes we want to get a repeat sleep study after doing the tonsils and the adenoids to make sure that we've made a good improvement or that it's gone. And if there's some sleep apnea that is still present, how are we going to continue to treat it? Okay. So there's not always a home run with just tonsils and adenoids. Sometimes there can be some sleep apnea that's left over. Okay. And there are other surgeries that we can do to help with residual sleep apnea, or we can refer them to our sleep colleagues that are more in the medical realm to help with continuous positive airway pressure or that CPAP mask. Okay. That's great to know. Yeah.
And what does the surgery actually look like? How long does it take, and what does the recovery time look like for patients?
Yeah. So in general, patients will come into pre-op. You have to be there, I think, a few hours ahead of time, get everything set up. The surgery itself is pretty quick. It's probably like 30 to 40 minutes. For parents, maybe it takes a little bit longer for them. By the time the patient goes back with the anesthesiologist, goes to sleep, gets an IV after they're asleep, and those kinds of things. So it's probably a little bit longer for the parents than it is for the child. But the surgery is fairly quick. It's something that we do a lot of. So this is a fairly routine procedure for us. In terms of recovery, there are different schools of thought, and different ENTs may have different approaches to how they approach post-operative care. Myself, I don't really make any limitations on what they can or can't eat after surgery. I tell parents it's a good rule of thumb. If you can draw a piece of food across your arm and it can cause a scratch, I don't really want your kid eating that because the back of the throat will be raw. But other than that, I let kids kind of guide themselves. For small children, I don't put any activity restrictions on them because good luck with that. But for older kids that are in competitive sports, I like for them to wait usually 2 weeks to really get their blood pressure up and elevated and breaking a sweat in sports. So most kids on average need, I tell them they can go back to school when they're off of narcotic medications. Every kid is different. So some kids, do really, really well after surgery, and some kids struggle after surgery with pain and oral intake and things like that. In general, I would say most kids are back in school in a week.
Oh, that's great.
Yeah.
That's really great. Is there a certain age that they have to be in order to have the surgery?
There's not.
Any age? Okay.
No, it really can be any age. Of course, we're a little bit more conservative with our young little ones, and they want some more information, like a sleep study, to really confirm that we're doing the right thing for that child. So the only difference is how we approach postoperative care. So we admit every child under the age of 3.
Okay.
And depending on if we have a sleep study, we always admit children with severe obstructive sleep apnea into the hospital overnight. Or there's some other reasons. So if they live far away, I may want to keep them overnight to make sure that they do okay before they're far away from me if they need me. Other kids, some mamas come in and they're like, sensory issues, or maybe they really struggle with oral intake anyway, then we may want to keep that child in the hospital and make sure that they're going to be able to eat and drink enough to stay hydrated. So there's a few reasons why we would keep children in the hospital afterwards. Other times we can send them home. So it depends on the kiddo.
Okay, that's great. Is there any sort of reason why care of or not treated?
Yeah, I would say that, with every surgery, there's definitely risks. And so one reason that a parent may elect to not have surgery is because they want to try something else first. So maybe they want to try CPAP first, and that's totally an acceptable method to treat sleep apnea. And so if parents are resistant to surgery, we can absolutely set up a consultation for them to try that.
Okay.
And if their kiddo doesn't like it or won't leave it on their face or whatever overnight, then maybe that is worthwhile for them to have at least tried that before going to surgery.
Okay.
There are also some medications that we try actually for sleep apnea. So intranasal steroids, the most common one is probably Flonase or fluticasone. That can be useful for treating mild obstructive sleep apnea in addition to Singulair. So Singulair is an allergy medication, but has also been shown to be helpful in the treatment of obstructive sleep apnea. So for some kids, if they have mild sleep apnea or mild symptoms, or on exam they look like really the nose is affecting them a lot, then we might try a medical course first, especially if the parents are more reluctant to proceed with surgery.
Okay.
Other times you look in the throat and you're like, these tonsils they're kissing in the midline. Like, we're gonna make our best treatment by taking these out. So again, it kind of depends on the patient and their anatomy, and that discussion with parents and that shared decision-making process where we talk about it and we make a plan together. It's not just about what I want,
Yes.
It's about what is the best for, the family.
Mm-hmm.
So those are some things in terms that we can try. So some parents and families, they may just want to try that first, and that's great. Other things to think about with surgery is, like I said, there's always risks. So the most significant risk of a tonsillectomy, I think, is what we call a post-tonsillectomy hemorrhage, or bleeding after a tonsillectomy. That most commonly occurs 7 to 10 days after. Commonly.
Okay.
but if it happens to your kid, it feels common. So that's the most significant risk. Other risks of surgery, we're operating through the mouth. So we always have a risk with any surgery anywhere in the body, a risk to surrounding structures. So when operating through the mouth, you can injure the teeth, lips, gums, tongue, any of those nearby structures. That again is not very common, but theoretically can happen. Failure to cure, that's a fancy way to say we can do this surgery, but you may still have some sleep apnea after surgery, or we may make some improvements, but there might be some residual. So that's another one. And then potential need for subsequent procedures. So that could either be controlling bleeding, if that were to happen to your child after a tonsillectomy, or having that residual sleep apnea and going back to surgery to see if we could make it better. I think that those are the main things that we kind of think about. And, people have to kind of weigh where they are in terms of the benefits from treating obstructive sleep apnea versus the benefits or risks of surgery. And that's something that we always are weighing when we make recommendations to families.
It's really nice that there are other options and that you include the family in the process.
Absolutely.
Because I know that is so important.
Absolutely. So, obviously there's a spectrum, and depending on the severity, you may recommend one option over another. But like I said, it's a discussion.
That's the great thing about Phoenix Children's is that we really highlight that family-centered care, which is so important.
Yeah.
Okay, for next steps, if a parent thinks their child has sleep apnea, should they go to their PCP first, and do they need a referral to come to our ENT division, or how does that process work?
I think it probably depends on their insurance whether or not they need a referral or whatnot, but we're happy to see any and all kids that come through the door. So we're really lucky in Phoenix. We've got great primary care providers, both in and outside the institution, that I think that I always am getting very appropriate referrals, and so I would say pediatricians are screening for this also. The American Academy of Pediatrics recommends that pediatricians are asking families about this kind of thing. And so that's definitely something that may prompt a referral. It's certainly something that you can talk to your pediatrician about. Or if you're like, that is my child is stopping breathing at night, absolutely, we're happy to see if you want to make an appointment with us directly.
Okay.
Yeah.
Wonderful. Thank you. Is there anything we didn't touch on that I think we pretty much
I've been talking
covered
your
it
ear
all?
off.
It's very useful and very helpful.
No, I'm happy to answer any questions if there are any.
But we'll make sure we send you any that come in, so people can post questions after we end, and we'll send them your way. But this has been very, very insightful. Thank you.
Good, yeah.
You're very helpful with explaining the whole process, so thank you.
Well, thank you for having me. I am passionate about getting kids to sleep better and getting them to feel better during the day, which I think not restful sleep really impacts kids. So I think we make a really positive difference in kids' life by sleeping better, and parents' lives too.
Yes, definitely.
Yes.
I think parents would probably agree with that 100%.
Yes.
Well, thank you very much.
You're so
we'll send
welcome.
you questions your way, and thank you for tuning in, and keep an eye on our Facebook page for additional Facebook Lives coming your way.